Good morning everybody, and today what we're going to discuss is thyroid disorders. As I've said many times, if you need to contact me, please use this email address here. Right, the thyroid itself, right, and thyroid hormones, right, are what we're going to discuss here. But in terms of thyroid disorders, these involve either thyroid hormone production or secretion resulting in alterations in metabolic stability. T3 and T4 are formed on thyroglobulin. Thyroglobulin is a large glycoprotein which is synthesized within the thyroid gland. Inorganic iodides enter the thyroid follicular cell and are oxidized by thyroid peroxidase and covalently bound to tyrosine residues of thyroglobulin. Monoiodinated tyrosine and diiodinated tyrosine are used to form iodothyronines in a reaction that is catalyzed by thyroid peroxidase. Now, it's worth pointing out that iodinated tyrosine residues such as monoiodotyrosine and diiodotyrosine couple to form iodothyronines in reactions that are catalyzed by thyroid peroxidase, and the two molecules of diiodotyrosine will then form T4, and a combination of monoiodotyrosine and diiodotyrosine will form T3. T3 and T4 are transported by thyroid binding globulin. Proteolysis within the thyroid cells itself release thyroid hormone into the bloodstream. T3 and T4 are transported by thyroid binding globulin, transthyretin and albumin. Only unbound or free thyroid hormone can of course diffuse into the cells and elicit a biological effect and regulate both thyroid stimulating hormone secretion from the pituitary. T4 is made within the thyroid, T3 is formed from the breakdown of T4, and T3 itself is actually 5 times more active than T4. Right. Approximately 20% of T3 is actually made in the thyroid gland. Most of it, of course, is made from the breakdown of T4, right, which is catalyzed by an enzyme known as monoiodinase in the peripheral tissues. Of course, T4 may also be acted on by monoiodinase to form reverse T3, which is biologically inactive. Thyroid hormone production is regulated by the pituitary or the anterior pituitary through thyroid stimulating hormone, which in turn works under a negative feedback control or negative feedback loop by controlling the circulating levels of free thyroid hormone and the positive influence of the hypothalamic thyrotropin releasing hormone, right, or TRH. Thyroid hormone production can be affected by nutrition, right, non-thyroidal hormones, drugs, and even illnesses. Now, what about laboratory tests that are used in the diagnosis and treatment of thyroid disease? The first one we're going to look at is thyroid stimulating hormone, also known as thyrotropin. And this is produced by the anterior pituitary gland in response to thyroid releasing hormone. Right, and of course it stimulates the secretion of T4 and T3 from the thyroid. It is regulated by a negative feedback loop inhibition by both T3 and T4. In other words, high levels of T3 and T4 will result in reduced levels of thyroid stimulating hormone. Primary testing for screening and monitoring of thyroid replacement therapy is why we would use thyroid stimulating hormone. Total thyroxine or T4 is free and bound. T4 is primarily bound to albumin, prealbumin, and thyroxine binding globulin. The remaining free active fraction The remaining free fraction is the active portion, and of course It is affected by binding abnormalities, and abnormal levels may indicate a protein abnormality of some sort, like a lack of albumin or prealbumin, or globulin for that matter. Free T4, on the other hand, represents the active portion of T4. It's directly measured and is more reliable than the total T4 levels. It is, of course, the precursor to T3, which we know is 5 times more active than T4, and it is a measure of the actual thyroid function itself. When it comes to T3, or triiodothyronine, it is produced from peripheral deiodination of T4 when it is useful in the monitoring of thyrotoxicosis. Thyroid stimulating hormone receptor antibody is an autoantibody for the TSH receptor on the thyroid gland. It mimics TSH and stimulates the TSH receptor, and it obviously confirms Graves' disease. Thyroid peroxidase antibody is an antibody against thyroid peroxidase in the thyrocytes. The presence identifies autoimmune disorders, and it predicts conversions of subclinical hypothyroidism to overt hypothyroidism. Of course, thyroglobulin antibodies are used as an adjunct to thyroperoxidase to diagnose Hashimoto's thyroiditis, and are used, of course, in monitoring thyroglobulin levels in thyroid cancer. So the first thing we're going to discuss is thyrotoxicosis. Now, thyrotoxicosis results when tissues are exposed to excessively large amounts of either T3 or T4 or both. Hyperthyroidism is just one cause of thyrotoxicosis. Thyroid stimulating hormone secretory pituitary tumors occur sporadically and release biological active hormones that are unresponsive to the normal negative feedback loop. In so doing, right, you will have a large amount of T3 and T4 that way. The tumors may secrete prolactin or growth hormone. Therefore, the patient may also present with other condition or other symptomology that we have discussed before, from high levels of either prolactin or growth hormone, such as amenorrhea, galactorrhea, or even signs of acromegaly. Graves' disease is by far the most common cause of hyperthyroidism, and it is caused by thyroid stimulating antibodies which are directed against the thyrotropin receptor on the surface of the thyroid cell. These immunoglobulins then bind to the receptor and activate the enzyme adenylate cyclase in the same manner that TSH would, and in so doing will then result in an increase in T3 and T4. A toxic adenoma is usually one that is greater than 3 centimeters in diameter. Right? A Derquavine's thyroiditis, right, often occurs as a result of or after a viral syndrome itself, but is rarely caused by any specific virus that has been identified in the thyroid parenchyma. Right. It's worth noting, however, that a painless thyroiditis is also a common cause of thyrotoxicosis. A painful subacute thyroiditis, on the other hand, right, or Derquavine's thyroiditis, like we said, occurs after a viral syndrome and is usually painful. Now, a painless thyroiditis, on the other hand, has its etiology which is not well understood, and autoantibodies may actually be the cause. Thyrotoxicosis factitia is hyperthyroidism, usually due to the ingestion of exogenous thyroid hormone. Now, this is usually occurs as a result of inappropriate indication for the use of thyroid hormone, excessive doses of thyroid hormones above those accepted for the use of their medical indication, or even accidental ingestion of thyroid hormone. Amiodarone is known to cause both hyper and hypothyroidism, right? And it interferes with 5-deiodinase, leading to reduced conversion of T4 to T3 and iodide release from the drug may contribute to excessive iodine excess. Amiodarone can cause destructive thyroiditis with loss of thyroglobulin and thyroid hormone. Now, in terms of the symptomology or clinical presentation in these patients, usually they present with palpitations, emotional lability, heat intolerance, weight loss, increased appetite, amenorrhea, and then anxiety. These are the general symptomology. Other physical signs include warmth of the skin, which is moist and usually smooth, and they usually have fine hair, and there is a separation of the fingernails from the nail bed itself, so there's almost like a retraction that takes place there. Now, some patients may also present with retraction of the eyelids and lagging of the upper eyelids behind the globes, resulting in a downward gaze. Right? Additionally, some patients may have widened pulse pressures, they may have tachycardia at rest, they may even have a systolic ejection murmur. Occasionally, depending on the cause, you may get gynecomastia in men. Fine tremors of the protruded tongue and outstretched hands indicate, and of course, hyperactive deep tendon reflexes could also indicate a hyperthyroid-like state. And of course, thyromegaly is usually present. Now, in terms of Graves' disease, this is usually where you will find a diffusely enlarged thyroid, as well as exophthalmos and of course myxedema in certain cases. In a severe infection, a thrill itself may be felt and a systolic bruit may be heard over the thyroid gland itself. In terms of subacute thyroiditis or painful de Quervain's thyroiditis, usually the pain will be over the thyroid gland itself, and the systemic symptoms will include a fever, malaise, myalgia, and there will also be signs and symptoms of thyrotoxicosis, such as, for example, tachycardia at rest, widening pulse pressures, retraction of the eyelid, and even stuff like hyperreflexia, palpitations, heat intolerance, emotional lability, weight loss, etc. The thyroid gland is generally firm and tender on physical examination of these patients, and remember, we've already discussed how to examine the neck before. Painless thyroiditis usually has a triphasic course, in that it mimics painful thyroiditis as well. Most patients will present with mild thyrotoxicotic syndrome, lid retraction, and lid lag is also present, but exophthalmos tends to be absent, which is very important to note that in comparison to Graves' disease, painless thyroiditis does not have exophthalmos. The thyroid gland may be diffusely enlarged, but it is not tender, and that is what differentiates painless thyroiditis from de Quervain's thyroiditis. Other than, of course, the pain, it is that the thyroid gland is diffusely enlarged but not tender to the touch. In terms of the thyroid storm itself, this is usually a life-threatening medical emergency, which is a form of decompensated thyrotoxicosis. The patient will present with a high fever of greater than 39.4 degrees centigrade, along with tachycardia, tachypnea, dehydration, delirium, coma, nausea, vomiting, and diarrhea. Precipitating factors include infection, surgery, radioactive iodine therapy, and withdrawal of certain anti-thyroid drugs. In order to diagnose patients, we need to use what we would call the elevated radioactive iodine reuptake, which is a true indication of hyperthyroidism rather. A low level of radioactive iodine uptake indicates excessive thyroid hormone, and this is not a consequence of thyroid gland hyperfunction, but is largely or most likely caused by either thyroiditis or hormone ingestion. TSH-induced hyperthyroidism is diagnosed by a diffusely enlarged thyroid gland, which you would be able to see on imaging, along with elevated free thyroid hormone levels and elevated serum immunoresponsive or immunoreactive TSH concentrations. TSH secreting pituitary adenomas are diagnosed by demonstrating a lack of TSH response to TRH stimulation, and there will be inappropriate TSH levels and elevated TSH alpha subunit, and radiological imaging which will also be required. In simple terms, to be able to tell that a patient has a hyperthyroid state or hypothyroid state, you need to look specifically at their T3, T4, and of course their TSH levels, as well as so in this we call our thyroid panel essentially. And what we would look at in a hyperthyroid state is that for total T4 and free T4 would be increased, but there would be a marked increase in T3 levels with a marked decrease in TSH levels. In a hypothyroid state, you would find that, of course, T3 and T4, right, are usually reduced, but T4, both total and free T4, are markedly reduced in comparison to T3, and TSH is markedly increased because of the negative feedback loop that is in play here. And of course, where there is increased thyroid binding globulin, there will be an increase in T4 total, but the normal free T4 will be normal, and of course the T3 will be increased and TSH will be normal. Ultimately, the diagnosis of a toxic adenoma itself may be isolated by evaluation of the serum T3 levels. T3 levels must be measured to rule out T3 toxicosis if the T4 levels are normal. Multinodular goiters require a thyroid scan or functional MRI scan which will show patchy areas of autonomously functioning thyroid tissue. A low radioactive iodine uptake indicates excessive thyroid hormone that is not a consequence of either enlargement, that is not a consequence of thyroid gland hyperfunction. Right? A low level of radioactive iodine uptake may be seen in painful subacute thyroiditis or de Quervain's thyroiditis, painless thyroiditis, strumi ovary, follicular cancer, and even factitious ingestion of exogenous thyroid hormone, also known as thyroiditis factitia. Right. In terms of subacute thyroiditis, thyroid function tests typically run a triphasic course, and it is and the disease itself tends to be self-limited. Initially, T4 is elevated due to the release of preformed thyroid hormone. The 24-hour radioactive iodine levels during this time is less than 2% because of the thyroid inflammation and TSH suppression via the elevated T4 levels. As the disease progresses, intrathyroidal hormone stores become depleted and the patient becomes more rapidly hypothyroid in nature with appropriately elevated TSH levels. During the recovery phase, thyroid hormone stores are then replenished and serum TSH levels are elevated gradually, which then return to normal. Of course, during thyrotoxicosis or the thyrotoxicotic phase of painful thyroiditis, the 24-hour radioactive iodine level is generally suppressed to less than 2%, and anti-thyroglobulin and anti-thyroid peroxidase antibody levels are elevated to more than 50% of what is considered normal. Thyrotoxicosis factitia should be suspected in thyrotoxic patients, right? Without evidence of increased hormone production, thyroidal inflammation, or ectopic thyroid tissue. The radioactive iodine is low because the thyroid gland function is suppressed by exogenous thyroid hormone. Measurements of plasma thyroglobulin will reveal the presence of low levels. Now, the goal of therapy, of course, is to eliminate excessive thyroid hormone, to minimize symptoms and long-term consequences, to provide individualized therapy based on the type and severity of the disease, as well as the patient's age, gender, existence of non-thyroidal conditions, and of course the response to previous therapy. In terms of non-pharmacological therapy, we know that surgical removal of the thyroid gland should be considered in patients with a very large thyroid gland that is greater than 80 grams, or if they have severe you know what the word means, I'm not going to say it, ophthalmopathy, yeah, there we go, you got it. Now you can all laugh at me. A lack of remission on anti-thyroid drug treatment. You may of course need certain pharmacological agents before you actually perform the thyroidectomy. So if the thyroidectomy itself is planned, methimazole, right, which is the active form of carbimazole, is usually given until the patient becomes biochemically euthyroid, which usually is 6 to 8 weeks, after which it is followed by iodides, usually 500 milligrams per day, for 10 to 14 days prior to surgery to actually reduce the vascularity around the thyroid gland. After which, levothyroxine may be considered to maintain the euthyroid state while thioamides are continued. Propranolol may also be used for several weeks post-operatively. So once you have actually removed the thyroid gland, you may consider the use of propranolol for at least and should be used for at least 7 to 10 days and can be used for up to several weeks to maintain the pulse rate of less than 90 beats per minute. Combined pre-treatment with propranolol and 10 to 14 days of potassium iodide has also been advocated in these scenarios. So one of the pharmacological managements that we can consider is of course thioamides, and the two common ones they are methimazole and propylthiouracil. Methimazole is of course the active form of carbimazole. The usual initial dose of methimazole is usually 30 to 60 milligrams daily in 2 to 3 divided doses, whereas propylthiouracil is dosed anywhere between 300 to 600 milligrams per day, usually in 3 to 4 doses. There is evidence that both drugs can be given as a single daily dose, and improvement in terms of laboratory abnormalities are usually within 4 to 6 weeks, so that is after which you can start tapering the dose. The maintenance dose of methimazole is somewhere between 5 to 30 milligrams a day, and therapy is usually continued for 12 to 24 months in order to induce long-term remission of the thyroid gland itself. Now, we must monitor patients every 6 to 12 months for remission. If a relapse occurs, alternative therapy with radioactive iodide is then preferred over either methimazole or propylthiouracil, as opposed to swapping between methimazole or propylthiouracil depending on which one you have used first. The most common adverse effects include pruritic maculopapular rashes, arthralgias, fevers, and benign transient leukopenia. Right? Major adverse effects of these drugs include fatal or can be fatal agranulocytosis, aplastic anemia, and of course lupus-like syndrome, polymyositis, GIT intolerance, hepatotoxicity, etc. If agranulocytosis does develop within the first 3 months of therapy, routine white blood cell count monitoring is not recommended because of its sudden onset. And let me just say that again. If agranulocytosis does occur, it usually occurs within the first 3 months of therapy, and as a result of that, routine measurement of the white blood cell count is generally not recommended. Now, methimazole is preferred to propylthiouracil under almost all circumstances except in the following. In the case of first trimester pregnancy, we would prefer propylthiouracil. In terms of intolerance to methimazole, we will prefer propylthiouracil. In terms of thyroid storm, we will prefer propylthiouracil. We must monitor the patient every 6 to 12 months after remission, and of course, like I said, if remission occurs followed by relapse, we will then consider alternative radioactive iodine therapy as opposed to switching to another thioamide. In terms of the iodides themselves, they of course produce symptomatic improvement, and that occurs within 2 to 7 days after initiating therapy, and T3 and T4 concentrations are usually reduced within a few weeks. Now, iodides are often used as adjunctive therapy to prepare patients who are with grave disease who are undergoing surgery, or alternatively for acutely inhibiting thyroid hormone release and quickly attaining a euthyroid state in severely thyrotoxic patients with cardiac decompensation. And lastly, they can be used to inhibit thyroid hormone release after radioactive iodine therapy. We typically start with a saturated solution of potassium iodide, or SSKI, which is given at 3 to 10 drops per day, either in water or juice. When patients are prepared for surgery, it should be administered 7 to 14 days preoperatively. Saturated solutions of potassium iodide should not be used before, but rather 3 to 7 days after radioactive iodine treatment. In terms of beta blockers, they tend to ameliorate the symptoms such as palpitation, anxiety, tremor, and heat intolerance, but they have no effect on thyrotoxicosis and do not prevent thyroid storm. Beta blockers are usually used as an adjunctive therapy with antithyroid drugs such as either carbimazole, methimazole, or propylthiouracil, or radioactive iodine or iodides when treating Graves' disease or thyrotoxic nodules in preparation for surgery or in thyroid storm. Beta blockers are the primary treatment for thyrotoxicosis as associated with thyroiditis. Propranolol doses are required to relieve adrenergic symptoms such as tremors, for example, heat intolerance, palpitations, anxiety, vary, but the initial dose is somewhere between 20 to 40 milligrams given 4 times a day and is effective for most patients to achieve a heart rate of less than 90 beats per minute. Younger or more severely thyrotoxic patients may require much higher daily doses in the region of 240 to 480 milligrams per day, perhaps because of their increased clearance of the drug itself. Beta blockers are of course contraindicated in decompensated heart failure unless that is caused solely by tachycardia, so it's a high output decompensated heart failure. Other contraindications such as sinus tachycardia, concomitant therapy with monoamine oxidase inhibitors or tricyclic antidepressant, and patients with spontaneous hypoglycemia. Importantly, remember that these drugs will affect the patient's sleep, so they may cause insomnia, lightheadedness, bradycardia, and even hematological disturbances. If a patient cannot use beta blockers for whatever reason, in that it is contraindicated, we can use some patholytic agents such as clonidine, or alternatively we can consider calcium channel blockers such as diltiazem in these patients. In terms of radioactive iodine, or I-131, it is the agent of choice for Graves' disease, toxic autonomous nodules, and toxic multinodular goiter. Pregnancy is an absolute contraindication for the use of radioactive iodine because radiation will, of course, would be delivered directly to fetal tissue itself and will, of course, be teratogenic or mutagenic depending on the stage of the pregnancy. Beta blockers are primarily adjunctive therapy to radioactive iodine therapy, primarily because they may be given at any time without compromising radioactive iodine therapy. If iodides are administered, they must be given 3 to 7 days after radioactive iodine therapy and never before radioactive iodine therapy to prevent interference with uptake of radioactive iodine in the thyroid gland. Now, hypothyroidism usually occurs 1 month to years after radioactive iodine therapy. The acute short-term side effects include mild thyroidal tenderness and dysphagia. Long-term follow-ups have revealed no increased risk of the development of mutations or congenital defects once radioactive iodine therapy has been stopped. In terms of thyroid storm, remember that thyroid storm is quite a severe disease and requires therefore treatment with propylthiouracil as opposed to methimazole. Propylthiouracil at a dose of 9 to 1200 milligrams orally in 4 to 6 divided doses is used and is the preferred thioamide. Beta blockers such as propranolol at 40 to 80 milligrams per day are generally 40 to 80 milligrams every 6 hours are generally used for thyroid storm. Sodium iodide can be given at 2 grams IV as either a single or divided dose. Alternatively, Lugol solution of 5 to 10 drops 3 times a day in a glass of water or juice may be considered, or saturated solutions of potassium iodide 1 to 2 drops 3 times a day in water. Now, an alternative to this is, of course, to use glucocorticosteroid therapy. Glucocorticosteroids such as prednisone given 25 to 100 milligrams orally in divided doses, or methylprednisolone given 20 to 80 milligrams daily IV in divided doses, or hydrocortisone anywhere between 100 to 400 milligrams IV in divided doses can be considered. And but there is no convincing evidence of adrenocortical. There is no convincing evidence that these drugs will actually be of benefit in terms of thyroid storm, but rather that their benefits may be attributed to the antipyretic action and, of course, their stabilization of the patient's blood pressure. Remember that in the case of a thyroid storm, the patient will have a very high fever, which is one of the symptoms of the thyroid storm. Additionally, they will have tachycardia, delirium, coma, nausea, vomiting, and diarrhea. They may also have reduced levels or reduced blood pressure levels as well. In terms of evaluating the patient's therapeutic outcomes, right, you must consider that after therapy, which is either surgery, thionamides, or radioactive iodine for hyperthyroidism that has been initiated, you must evaluate the patient monthly until they reach a euthyroid state, after which it will then depend whether you're going to evaluate them every 6 to 12 months. Basically, assess for clinical signs and symptoms of continuing thyrotoxicosis or the development of hypothyroidism. If T4 replacement is initiated, the goal is to maintain both the free T4 levels and TSH concentrations within the normal range. Once a stable dose of T4 is identified, monitor every 6 to 12 months. Now, the next condition that we're going to discuss is hypothyroidism. Now, hypothyroidism itself is defined as a condition where the thyroid gland is unable to make adequate thyroid hormone to meet the requirements of the peripheral tissue. Essentially, we are going to go through 3 types of hypothyroidism. primary hypothyroidism, secondary hypothyroidism, and subclinical hypothyroidism. So, distinguishing between the three, it's important to remember in primary hypothyroidism, the thyroid gland fails to produce sufficient quantities of thyroid hormone to maintain a normal TSH secretion. As a result of that, right, what you will end up is with a decrease in the thyroid hormone levels, were followed by a sufficiently large increase in TSH levels. There is also failure of the negative feedback, resulting in elevated TSH levels, like I suggested. The vast majority of patients have primary hypothyroidism, and this is due to thyroid gland failure from an autoimmune thyroiditis such as Hashimoto's thyroiditis. Defects in suppressor T lymphocyte function leads to survival of randomly mutating clones of T helper lymphocytes directed against antigens on the euthyroid membrane. The resulting interaction stimulates B lymphocytes to produce thyroid antibodies. In terms of subclinical hypothyroidism, right, there is usually this usually requires a repeated serum TSH level to be elevated above the normal range, but the patient will have normal T4 and normal free T4 and free T3 levels, which are stable over weeks, occurring in the absence of hypothalamic pituitary disease, and there will be no recent non-thyroidal illness. Now, it's worth noting that subclinical hypothyroidism may be considered or fall into two categories. Those where the TSH level is greater than 10 micro-international units per liter, or those where the TSH level is roughly between 4 and 10 micro-international units per liter. Now, it is important to differentiate between younger patients and older patients. Those who are less than 65 and those who are between or greater than the age of 80 years old. As TSH increases with age, and is thought that a rising TSH level can confer some physiological advantage. Subclinical hypothyroidism is associated with an increase in coronary artery disease, including both coronary heart disease events and mortality from coronary heart disease. The risk of coronary heart disease and, of course, coronary heart disease mortality or coronary artery disease mortality increases with an increase in TSH levels. As a result of that, if their TSH levels are greater than 10, we then consider this as a must treat point. In other words, if their TSH levels is more than 10 micro-international units per ml, then per liter, we then consider this that we must treat them with thyroid replacement therapy. In secondary hypothyroidism, right, you will find that the disease is either because of the hypothalamus or the pituitary, resulting in inadequate TSH production and therefore insufficient stimulation of structurally and functionally normal thyroid gland. In early secondary hypothyroidism, the TSH may be normal but is biologically inactive, while the hallmark of secondary hypothyroidism being that you will have a normal or low TSH level and a low free T4 level. Secondary hypothyroidism is uncommon. Pituitary insufficiency may be caused by destruction of the thyrotropes by pituitary tumors, surgical therapy, external pituitary radiation, postpartum pituitary necrosis, such as Sheehan syndrome, trauma, and infiltrative processes of the pituitary itself. In terms of clinical signs and symptoms, most of the time patients will have dry skin, cold intolerance, weight gain, constipation, depression or loss of ambition, fatigue, loss of energy, muscle cramps, stiffness, infertility, heavy menses, hyperlipidemia. Myxedema is a very rare consequence of decompensated hypothyroidism, and of course it may be manifested by hypothermia and advanced stages of hypothyroid symptoms, as well as altered sensorium ranging for anywhere from delirium all the way to coma. Mortality rates are of course 60 to 70% in myxedema comas, and therefore they necessitate aggressive treatment. Most patients with secondary hypothyroidism due to inadequate TSH production have clinical signs of generalized pituitary insufficiency, such as abnormal menses, decreased libido, for example, and there is even evidence of pituitary adenomas such as galactorrhea, gynecomastia, and even acromegaly as a feature. Right, in terms of diagnosis, primary hypothyroidism accounts for 99% of all cases of hypothyroidism, and of course it will be the TSH level which will be elevated, and that is the appropriate screening test. If TSH is elevated, serum free T4 levels should be measured. Free T3 and reverse T3 levels are not required for the diagnosis of primary hypothyroidism, and the management of patients with primary hypothyroidism or subclinical hypothyroidism remains the same. Remember, the treatment level for subclinical hypothyroidism is dependent on the TSH levels. If the TSH levels are greater than 10 micro-international units per liter, and taking into account that this will be a younger person, then of course we will consider treatment. Thyroid antibodies are useful to confirm autoantibodies and should only be measured at the time of diagnosis. Once diagnosis is made, they are of no use whatsoever, and they play no role in the ongoing management of the patient, so do not need to be measured thereafter. In terms of secondary hypothyroidism requires you to check the free T4 levels for screening. There is generally no consensus about population screening. The American Thyroid Association itself recommends that the TSH levels should be measured from age 35 every 5 years thereafter. The American Association of Clinical Endocrinologists, however, suggests screening older adults, but the age is not specified, but they say you should definitely screen women. The US Preventative Screening Task Force, however, concluded that there was insufficient evidence to recommend either the use of screening via TSH. However, there are some patients who you can consider screening for TSH. Those with symptomatic hypothyroidism, those with other autoimmune disorders such as type 1 diabetes, those with a family history of autoimmune thyroid disease, those with a history of neck radiation or radioactive iodine therapy, those with a prior history of thyroid surgery or dysfunction, those of course who have psychiatric disorders, patients either taking amiodarone or lithium, because both can reduce thyroid levels and cause a drug-induced hypothyroidism, infertility, and of course repeated miscarriages, growth retardation, and delayed puberty. Others are pregnant women with risk factors, those with genetic syndromes such as Down syndrome or Turner syndrome, hyperprolactinemia, dyslipidemia, heart failure, chronic constipation, and of course dementia, but also patients who are obese, and the hypothyroidism may be the reason why they are unable to lose weight. In terms of primary hypothyroidism, levothyroxine monotherapy is considered the standard of care, or what we will generally use, but there is a lack of trial or randomized controlled trial evidence comparing levothyroxine to the placebo. Withdrawal of levothyroxine will result in a recurrence of signs and symptoms of hypothyroidism. And of course, when we are treating patients with levothyroxine, we must remember to inform the patients to take the levothyroxine either 60 minutes before breakfast or 4 hours after their last meal of the day to ensure that they receive the best absorption for their drug. Right? There is, however, no data to suggest which one of these two strategies is more superior. There are a number of factors which can affect the absorption of the drug. The factors that can affect the absorption of the drug include other dietary factors such as ingestion of a meal, espresso, coffee ingestion, high fiber diet, soybean formula, even soy itself, and of course grapefruit juice. Drugs themselves can also affect the absorption of levothyroxine, such as bile acid sequestrants, sucralfate, cation exchange resins, oral bisphosphonates, proton pump inhibitors, raloxifene, multivitamins, ferrous sulfate, calcium salts, etc. Alright. May also charcoal, orlistat, ciprofloxacin, all of these may of course affect the actual drug absorption itself. Right, in terms of primary hypothyroidism, patients with minimal or residual thyroid function or those who have a total thyroidectomy require about 1.6 micrograms of levothyroxine per kilogram per day. Younger, healthier patients can be initiated directly on the full dose. Those with cardiovascular disease require levothyroxine to be initiated at 25 micrograms of levothyroxine daily. And healthy patients over the age of 60 years must be initiated at 50 micrograms of levothyroxine daily. Dose adjustments may be required with aging, weight loss, and pregnancy. Recent studies have shown the clinical benefit of treating to normal TSH levels. So the goal TSH level is anywhere between 0.5 and 3 micro international units per liter, and we want to of course measure TSH levels every 4 to 8 weeks until the target is achieved. Once it's achieved, then of course we will measure it every 6 to 12 months. Dose adjustments generally need to be no higher than 12 to 25 micrograms per day, either titrated upwards or downwards depending on the scenario. In terms of subclinical hypothyroidism, we want here of course for the patient to in terms of secondary hypothyroidism, the levothyroxine dose here is 1.6 micrograms per kilogram once again, and we want to maintain the free T4 in the upper half of the normal range, right, because this will result in the best reduction in symptoms. We will of course measure free T4 in these patients every 4 to 8 weeks with secondary hypothyroidism. And of course, dose adjustments should generally be no higher than 12 to 25 micrograms per day, either up or down. Free T4 should be repeated every 4 to 8 weeks until the goal is achieved. Thereafter, free T4 is then measured only every 6 to 12 months. In terms of subclinical hypothyroidism, like I told you, the treatment cutoff point is where the TSH level is greater than 10 micro international units per ml. That is because there is the highest risk of coronary heart disease and death from coronary heart disease in these patients, and therefore it should be treated with levothyroxine monotherapy. Full replacement doses are generally not required. Anywhere between 25 to 75 micrograms is sufficient to achieve a euthyroid state. Older patients who are older than 65 years old or who have heart failure, ischemic heart disease or arrhythmias must be initiated on a lower dose, anywhere between 12 to 25 micrograms. Treatment for TSH here, you want to aim for a state of subclinical hypothyroidism, which is between 4 and 10 micro international units per liter but that is considered to be controversial. In terms of treating myxedema, myxedema itself requires immediate and aggressive treatment because of its high mortality rate. As a result of that, we will use IV bolus levothyroxine of 300 to 500 micrograms, so a fairly high dose. We will also give glucocorticosteroid therapy such as IV hydrocortisone 100 milligrams every 8 hours until coexisting adrenal suppression is ruled out. We will then maintain levothyroxine doses anywhere between 75 to 100 micrograms IV until the patient stabilizes, and then we can start oral therapy. We'll also supply supportive treatment such as adequate ventilation, ensure the patient is euglycemic, their blood pressure is normal, and their body temperature is normal. We then will diagnose and treat any underlying causes of the myxedema coma such as sepsis or an acute myocardial infarction. Thank you very much for your time, and that concludes this particular lecture.